Good afternoon. Welcome to Grand Rounds this afternoon. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations, and please give the CME committee any ideas that you might have in regards to future topics or future speakers. Today, I have the pleasure of introducing Dr. Lou Scallon. Dr. Scallon attended undergraduate at Creighton before moving to Iowa City, where he attended medical school, and then from there to the Medical College of Wisconsin, where he did his ophthalmology residency and was the chief resident there his last year. He is board certified by the American Board of Ophthalmology, and he has kindly accepted the CME committee's invitation to come today and update us on the ocular side effects of systemic medications. And please join me in welcoming Dr. Scallon.
Thank you, Dr. Hallberg. It's a pleasure to be here. So to start out, I want you to all cover one eye and then the other, and make sure you can read the bottom line here. And while you're reading it, make sure that you're here for the right topic. So today I'm going to talk about ocular side effects of systemic medications. Every day when I'm in my clinic, patients come to me with various problems, and many of them have long lists of systemic medications that they're on. And as you'll find out today, many of these medications have effects on their ocular health. So it's important for me as an eye provider to know about these side effects, but it's also important for you as prescribers of these medications to be aware of them as well. One thing that we're asked to screen for on a regular basis is hydroxychloroquine toxicity. The antimalarials, chloroquine and hydroxychloroquine, are used to treat malaria and connective tissue diseases such as discoid and systemic lupus and rheumatoid arthritis. Throughout the world, toxicity, especially with chloroquine, is very common. Up to 28% of people taking it long-term have some effect on the eye. Chloroquine is 2 to 3 times more toxic than hydroxychloroquine, which has been modified slightly and makes it much safer to use. Patients that take chloroquine for treating malaria take it at higher doses and for longer periods of time, so they're much more likely to get some toxic effects. In the United States, the risk of having toxicity related to hydroxychloroquine is very low. A study in ophthalmology in 2003 reported an incidence of 0.5%, so it's very low. But when I have patients coming in that are being started on this medication, a lot of them are really concerned that it's going to damage their eyes. So I reassure them that it can be very safe and effective if they're monitored for side effects. The problem with hydroxychloroquine toxicity is that it affects the central vision. And this is due to a toxicity of the drug on the retinal pigment epithelium and the neurosensory retina. The chloroquine component of the medication binds melanin. In the early stages, the photoreceptors, the rods and cones, are affected, and later on, the retinal pigment epithelium is also damaged. In the early stages, when you look inside the eye, you just see a little modeling of the pigment of the macula. In the full-blown hydroxychloroquine toxicity, you see a bullseye pattern of depigmentation of the macula, and I'll show a photo of this in just a second. Sometimes we'll do fluorescein angiography to pick up the early stages, where we inject fluorescein dye into a patient's vein, and you can see hyperfluorescence caused by the absence of pigment around the macula. In advanced stages, you can see that the retinal arterioles are damaged, the optic nerve can become pale, and you can see some generalized pigmentary changes resembling retinitis pigmentosa. There are some risk factors to consider. A daily dose of greater than 6.5 milligrams per kilogram, use greater than 5 years, patients that have hepatic or renal insufficiency don't metabolize the drug as well and are more likely to develop toxic effects. Patients that are obese and are being dosed at a milligram per kilogram level tend to be more prone to having toxic effects. And patients that have pre-existing diseases such as macular degeneration also are more likely to have some toxicity. So the surveillance guidelines are a baseline examination within the first year of starting treatment, including checking their best corrected vision, dilating their pupil, and doing a baseline central visual field test to look for pre-existing scotomas. Once the maculopathy is detected, it's important that hydroxychloroquine be stopped immediately. There are numerous reports of continued vision loss after discontinuation. So early detection is vital, because sometimes, even though there can be some progressive loss, in some patients they actually improve if the drug is stopped promptly. One thing that really has revolutionized ophthalmology is a new technique that we have for assessing the back of the eye, and it's called spectral domain ocular computerized tomography. And this is a test that we can do where light is reflected on the retina, and as it's bounced back, we can measure the different reflective layers of the retina, and it's almost like we're looking at the eye in a histologic section. Years ago, if we wanted to look at and study the eye in this detail, it had to be post-mortem. But now we can actually do these tests on patients in the office. In the normal retina, you can see this layer here with these black circles is the choriocapillaris, or the vascular layer of the wall of the eye. This bright orange layer is the retinal pigment epithelium. This black line are the rods and the cones. And this outer orange layer is the outer junctional layer. And so these are the various layers of the retina. This is the fovea here. This is the foveal depression. And this is where we have our very best visual acuity, because there's a concentration of cones in this area. So this is a normal retina. The bottom is a patient that has early hydroxychloroquine toxicity. And we can see that they still have a foveal light depression here, but they've lost this outer junctional layer, and they've had some deterioration of the rod and cone layer here. So this helps us pick up early toxicity. So the surveillance guidelines are annual screening, especially after 5 years of use, where we do a general exam, including dilating the pupil, again checking their central 10-degree visual field, and now we do this spectral domain ocular computerized tomography to assess. In the early stages, in this patient, it's really hard to detect that there's anything going on here. Just maybe a little bit of modeling of the pigment in the center of the macula of both eyes. But when you do a central 10-degree field, you can see that this patient is starting to develop a scotoma around the center of their vision. In a more advanced case, you start to see depigmentation in the macula in a ring-type pattern and a more dense scotoma on visual field testing here. So we call this bullseye maculopathy. This is a patient that came to me who moved to Ames after being treated with hydroxychloroquine for 8 years, and she had already developed a classic full-blown bullseye macular pattern here. And we took her off of hydroxychloroquine, and she's done relatively well. This is her spectral domain OCT, and that you can see more advanced changes here, where there's no longer a foveal depression, because a lot of the rods and cones have been lost in this area. The outer junctional layer is lost, and this pigment layer, you can see how it's nice and thick right here. It's very thin, and so this correlates with that bullseye pattern of degeneration. So in summary, it's important to do these screening tests every year. An important thing that we do is counsel patients that as long as they're getting checked, they should be okay. But it is important to do this regular testing. And that's part of any of you that are seeing patients on this medication, you need to reinforce this as well. I wanted to present a patient that one of my partners saw a few years ago, a 39-year-old male that had intractable headaches. He had a past medical history of hypertension and migraines, and he was admitted for pain control and was treated with Topiramate. After this treatment was started, the next day he had worsening headaches and blurry vision. And on examination, his visual acuity had really dropped off to 2100. And he had a big myopic shift. He'd become very nearsighted, up to -5. His pupils were mid-dilated and fixed, and his intraocular pressure was 70, and his eyes were quite injected. So this looks like angle closure glaucoma. And you might think it's a typical case, but it was not. The key thing for him was that he was being treated with topiramate, which is a sulfa derivative used for treating epilepsy and migraine prevention. Topiramate, like any of the sulfa derivatives, can cause acute ciliocoroidal effusion syndrome, which is different than the regular angle closure glaucoma. This can happen days to weeks after these medications are taken. They can have blurred vision due to a myopia, and it looks like bilateral angle closure glaucoma. The incidence is 3 in 100,000 patients treated with sulfa derivatives. So ciliocoroidal effusion syndrome is caused by a swelling of the lens and the ciliary body, which causes the ciliary body, which is the muscle right behind the iris that helps focus our eyes, it becomes swollen. And the swelling of the ciliary body pushes the iris into the anterior chamber angle and closes it off. This response is idiosyncratic. You can't predict who's going to have it and who's not. It isn't just limited to people that have sulfa allergies. And there is an inflammatory component to it. So if you're treating anybody with any of sulfa derivatives, such as sulfamethiazole, acetazolamide, even hydrochlorothiazide, it's important to know that this can happen. This is not our patient's B scan, but it's a stock B scan on a patient with ciliocoroidal effusion. And here you can see a marked swelling of the choroid, the vascular layer behind the retina. So there's a big gap that should not be here. And on the anterior part of the eye, the ciliary body, the muscle that focuses the eye, is very swollen, and it's pushed the iris into the anterior chamber angle. So the treatment here is different than what you would treat an angle closure glaucoma with. It's important to stop the offending drug right away. We do treat with glaucoma drops, but instead of using pilocarpine, which constricts the pupil and can rotate the ciliary body even further anteriorly, we use cycloplegic drops. Topical steroid drops are used to treat the marked inflammation that you see in these patients. Sometimes laser peripheral iridotomy is done just to confirm that it's not regular angle closure glaucoma. So it doesn't really help, but sometimes it's done just to confirm the diagnosis. Tamoxifen is used to bind estrogen receptors to inhibit estrogen effect on certain tumor cells. A fairly common ocular side effect is crystalline retinopathy, where you can see these highly refractile crystals that start to develop around the macula. These are not visually significant, and they usually resolve after the drug is stopped. These patients can get macular edema or swelling of the macula, but this happens only in 0.6%. So not any major ocular side effects, but it's important to know that this crystalline retinopathy can be occurring in case you see it and wonder what's going on. Bisphosphonates such as Fosamax, Actonel, Zometa are used for treating osteoporosis, as you all know. They bind to calcium and help it to accumulate in the bones. It's important to know that a small percentage of these patients will develop significant ocular irritation because of them, including scleritis, which is a fairly severe inflammation and thickening and swelling of the sclera, as you see here. Episcleritis, which is a more mild injection of the eye. They can have also iritis or uveitis because of this and have really significant inflammation. So it doesn't happen very often, but it's important to be aware that it can. Digoxin or digitalis inhibits the sodium-potassium ATPase. This enzyme is also important in maintaining normal cone function in the retina. And so it can have some ocular side effects, especially in patients that have toxic levels. 11 to 25% of patients with digoxin toxicity have red-green color defects. They can have xanthopsia or yellow tinging of their vision. Sometimes they'll have weird kind of flickering or snowy disturbance to their vision. It does decrease the aqueous secretion in the eye, which is not necessarily a bad thing. As I was doing my research, I ran across this interesting theory about why the color yellow is so predominant in Vincent van Gogh's paintings. In the 19th century, digitalis was used for treating a lot of different things, not just heart failure. It included epilepsy, mania, asthma, and other diseases. And it was said that Van Gogh suffered from epilepsy and mania. And so it's interesting that he painted this portrait of his physician holding a foxglove plant, which is the plant from which digitalis is derived. At the time that he lived, there was no way to check digoxin levels, and probably hard to base dosing just using a plant extract. And so it's thought that perhaps Van Gogh suffered from xanthopsia, causing him to paint with yellow in so many of his paintings. He also suffered from glaucoma, so it might have made the starry nights look especially blurry to him. Very commonly, our patients are treated with antidepressants, and there's a whole variety of them that I'm listed here. Antidepressants have a number of potential ocular side effects. All of the antidepressants have an anticholinergic effect, and so they can result in blurred vision due to cycloplegia or decreased accommodation of the ciliary body inside the eye. They can have photophobia or light sensitivity, and very commonly dry eye syndrome. And you can see a patient with severe dry eye syndrome with a decreased tear meniscus here, very little tear film on the surface of the eye, and marked pitting or staining of the cornea. This is a very severe case. Corticosteroids can have a number of ocular side effects as well. One thing to really be keyed into is that they can elevate the intraocular pressure or cause glaucoma. They can cause cataract, central serous retinopathy, which is a localized swelling, and I'll talk about that more in just a second. If they're used topically around the eye, they can cause atrophy of the skin and ptosis of the eyelid. Central serous retinopathy is a localized detachment of the retina. It's like a blister. Just like you get a blister on your skin, it's a blister of the retina. And it can be idiopathic, even in people that are not being treated with corticosteroids. In idiopathic cases, it's much more common in men than females, and it's linked with being type A personalities. And people, sometimes that are under a lot of stress, are more prone to getting central serous retinopathy. This causes blurring and waviness of the vision. Other risk factors include pregnancy and high cortisol levels, such as in patients with Cushing's disease or patients that are using steroids of any kind, whether they're nasal, topical creams, or pills. This is a patient with central serous retinopathy, and you might be able to see this kind of oval change in the macula. And you can see that the retinal vessels are kind of bowed here. They're lifted up off of the pigment epithelium. So this is a accumulation of fluid underneath the retina. And here's an ocular computerized tomography of a patient with central serous retinopathy. And you can see this blister-like accumulation of fluid underneath the retina that's lifting it off the pigment epithelial layer. This is a patient with idiopathic central serous retinopathy. You can see a little blip there where there's a little fluid accumulating underneath the pigment epithelium, and this is where the fluid that's leaking underneath the retina is coming from. Usually this is self-limited and will improve on its own after a month or two. Patients that are being treated with corticosteroids, if they're going to have a raise in their intraocular pressure, it usually takes 2 to 4 weeks for this to happen. So if you have patients that you're treating with cortisone of any kind for more than 2 to 4 weeks, it's important that they get their intraocular pressure checked to make sure that they're not having a significant spike in their intraocular pressure. And this is topical drops, periocular creams, ointments, and systemic of any kind. Prednisone, nasal sprays, aerosol inhalers. Any of those things can cause a significant raise in the intraocular pressure. This is felt to be due to a decreased outflow of the aqueous humor. There are a subgroup of people that are at higher risk for this. People with pre-existing glaucoma can be suddenly worse if they're treated with steroids. Patients with diabetes mellitus and high myopia are also at higher risk. Usually, the elevation in intraocular pressure gets better if you take away the cortisol or cortisone. The time that it takes to get better is usually dependent on how long they've been treated. The type of cataract that develops with cortisone use is called a posterior subcapsular cataract, which is like a sandblasting or a frosting right inside the back capsule of the lens, and it looks kind of whitish or frosted there. This type of cataract, even in the early stages, is very debilitating to patients because they get a lot of glare from lights. And in fact, once in a while you'll see a patient like this and you'll have them come in and they can read the 20/20 line on the eye chart because they're looking around this frosted patch. But if they're trying to drive at night, it's like looking through a dirty windshield. It really causes a lot of glare and disability to them early on. Amiodarone is a powerful antiarrhythmic agent that's used. Keratopathy or pigment deposits in the cornea are very common. 70 to 100% of patients treated with amiodarone develop this vortex or swirling type pattern of pigment on the anterior part of the cornea. This really does not cause much visual problem at all. 10% have minimal decrease in their vision if it's really, really dense. And often it will regress if the amiodarone is stopped. But the more important thing for you all to know about amiodarone is that 1 to 2% of patients that are treated with it develop anterior ischemic optic neuropathy over a 10-year period. And this is a serious loss of vision for these patients. This is a stroke of their optic nerve. It's similar to what you would see in temporal arteritis, where a patient has a sudden loss of vision. Usually in patients with amiodarone, it's painless though. They don't have the jaw claudication and tenderness of their temporal artery like you would see in giant cell arteritis. But if you look in the back of the eye, you see the same clinical picture where you see swelling and erythema of the optic nerve and flame hemorrhages coming off of it. So it looks like papilledema, but as opposed to papilledema, you have decreased vision. Patients with papilledema don't have decreased vision, but these people do. This is kind of a classic visual field defect. It's called an altitudinal visual field defect, where the top or the bottom half of the vision is lost in these patients. And so some recovery is possible if you stop this. I had a patient 4 weeks ago that presented with this, and her CRP was it was like 3.2, so a little bit suspicious. So we felt she should have a temporal artery biopsy, and that was done, and it came back negative. So then we took her off her amiodarone, and she's gotten better, fortunately. She was just starting to get symptoms in her other eye. So something very important to be aware of. Amiodarone also can cause some anterior subcapsular opacities, but these are in the front part of the lens, and because they're in the front and the way the optics of the eye works, they really aren't visually debilitating. Avandia and Actose are categories of hypoglycemic agents that work as insulin sensitizers. And occasionally, about 0.2% of patients that are treated with this, they'll get macular edema or swelling of the macula. And it can be very significant. The problem with this is that patients with diabetes also get macular edema. So you've got to sort out whether it's due to their diabetes or whether it's due to the medication. This is an OCT of a patient with very significant macular edema. And you can see these little cystic-like spaces in their retina, right in the center of the fovea, really bulging the fovea up. So it causes a marked decrease in vision. So again, this computerized tomography is really helpful to us in diagnosing and sorting these problems out. Because if you look with your fundoscope at a patient with this, you really don't see anything. You have to get down to a microscopic level to really be able to assess this. Back 15 years ago, we would do fluorescein angiography on these patients and inject the fluorescein dye, and you could see leakage and swelling in the macula, and that's the way we used to make the diagnosis, but now we use the OCT. Another really important take-home thing that I'd like any of you that are treating patients or seeing patients with statins to know is that they can cause muscle weakness of the eye. And you all know probably that they can cause muscle weakness throughout the rest of the body. Some of your patients can't take them because they get muscle aching and cramps. But similarly, they can cause problems with the extraocular muscles. These drugs inhibit the enzyme HMG-CoA reductase. And so the ocular side effects are inflammation of the extraocular muscles. They can cause weakness of the muscles. And so patients that have been on these for a while can present with diplopia. And so the double vision they experience is not like a cranial nerve palsy where they, have a definite limitation that you can relate to a third, fourth, or sixth cranial nerve palsy. And it can be quite variable. It can almost look like myasthenia gravis. They can also get ptosis because of this and lid edema. Frauenfelder et al. Did a fairly extensive literature research in 2008 and found 256 case reports of diplopia, ptosis, or ophthalmoplegia associated with statins. And they found 62 reports of positive de-challenge, where the patients were taken off of the statins and they got better. 14 cases reported where they started them again, where their symptoms recurred. So if patients have new diplopia, that's one of the things that I consider doing is taking them off their statin for at least a little bit to see what happens. Sometimes if you put them on coenzyme A, it will help alleviate this. If it's really important that they be on statins, oftentimes we can treat their diplopia with prism in glasses. We deal with dry eye syndrome a lot. A lot of patients, especially in Iowa in the winter where it's dry, have really some significant discomfort because of burning and irritation related to dry eye syndrome. And so there are a whole list of medications that can cause dryness of the eye. Antihistamines, beta blockers, diuretics, anticholinergics, antidepressants we already talked about, and isotretinoin or Accutane. So in treating dry eye syndrome, we have patients use artificial tear drops. Sometimes we'll put little punctal plugs in, the little punctum or opening in the lower eyelid where the moisture drains off the eye. If you plug it, it's like putting a stopper in a sink. It'll help conserve the moisture that's there. Using Restasis or cyclosporin drops probably doesn't help most of these things because that helps the autoimmune dry eye syndrome, so it really wouldn't help these. It's important to know that medications can cause visual hallucinations, and sometimes these hallucinations are really disturbing to patients. Vasodilators or vasoconstrictors like beta blockers or nitroglycerin can cause shimmering or halo effect due to changes in the circulation in the occipital cortex. Phosphodiesterase inhibitors, and I'm going to talk about this more in just a minute, can cause dose-dependent bluish tinge to patients' vision. Anti-seizure, psychotic medications, and certain antibiotics such as sulfas and cephalosporins can rarely cause vivid hallucinations or even nightmares. Dopamine agonists used to treat Parkinson's disease can also cause hallucinations, ranging from just fleeting images, sometimes to form hallucinations where people can see objects. And bisphosphonates can cause visual as well as auditory and olfactory hallucinations. And these things can be really disturbing to patients if they're unfortunate enough to have them. Something that I battle on a weekly basis are the alpha-adrenergic blocking drugs. And they talk about this on television when they have their commercials, that if you're taking one of these, that you should notify your eye surgeon. Drugs such as tamsulosin, doxazosin, and trazodone block the alpha-adrenergic system. and they are used for treating prostatic hypertrophy. They relax the muscles in the prostate and the bladder neck, making it easier to urinate. But the problem for us is that it keeps the pupil from dilating well. And it also causes what we call floppy iris syndrome, where the iris becomes really thin and doesn't maintain its normal tone. And so when we're doing cataract surgery, it tends to want to pop out of the eye, and you can see that happening here. So it really doesn't help to stop these medications in preparation for cataract surgery, because once they've been on them for several months, the changes are chronic. So we don't ask people to stop them. But we have to be prepared to deal with this by using mechanical vices such as rings or hooks to manually open the iris while we're doing cataract surgery and to keep it open. Isotretinoin I'm going to talk about specifically because it has a number of ocular side effects. This is used to treat psoriasis, cystic acne, and other skin conditions. In the eye, it can cause a deficiency of the lipid layer or the oil layer of the tear film. And other ocular side effects, one of the serious ones is that it can cause papilledema related to increased intracranial pressure, which used to be called pseudotumor cerebri, but now is known as benign intracranial hypertension. It's not really benign, but it's called benign because there's no tumor causing it. The symptoms of elevated intracranial pressure are headache, transient blackouts of vision, particularly upon changing posture where you go from sitting to upright. They can have kind of a whooshing sound or a tinnitus. And if their intracranial pressure is really elevated, they can have diplopia related to a sixth cranial nerve palsy. The visual blackouts are caused by postural drops in blood pressure and secondary compromise of the blood flow to the retina through the tightly packed optic nerve. Because isotretinoin is related to vitamin A, it can cause night blindness and some toxic effects on the retina if it's used in high doses, and it can cause some keratitis and conjunctivitis or chronic irritation of the eye, and that's probably related to the changes in the lipid layer of the tear film. Other medications that can cause benign intracranial hypertension are oral contraceptives, cyclosporin, minocycline, tetracycline, nitrofurantoin, phenytoin, sulfa drugs, corticosteroids, and vitamin A. So if you have a patient with headaches, think about this. Antituberculous drugs we see occasionally in AIMS. We have some patients with active TB that are floating around. Ethambutol is sometimes used for treating active TB, and it's recommended by the PDR that patients that are being treated with ethambutol at greater than 15 milligrams per kilogram per day be examined every month. These patients can get a toxic optic neuropathy. It's not ischemic, but it's toxic. And there have been reports of severe irreversible vision loss in patients taking ethambutol. So it's recommended that they all have a baseline examination to include visual field, color vision testing, dilated fundoscopic exam, and visual acuity. And it's important if you have patients on this medication to counsel them that if they're having any visual symptoms, they should stop the drug right away and get checked. So this is a patient with ethambutol toxicity, and you can see marked pallor of their optic nerves, and you can see these central scotomas that have developed. Erectile dysfunction is a hot topic, and a lot of advertisements on television, and all of them have the disclaimer that if you're taking these drugs, such as Viagra or Cialis, that if you have visual disturbances, you stop them and get checked by your doctor. As you all know, they inhibit phosphodiesterase 5, which results in vasodilation of smooth muscle. And the ocular side effects are kind of a change in the color perception. Sometimes they have blue or blue-green tint. 11% of patients taking Viagra, 100 milligrams, could perceive a blue haze for up to 4 hours. Sometimes dark colors appear darker. And there have been reports of non-arteritic anterior ischemic optic neuropathy in patients taking these medications. And this has been kind of a controversial topic for a while, whether these drugs are linked to ischemia of the optic nerve head. As you all know, the vasodilation, the smooth muscle, in some patients can drop their blood pressure, and anybody that has a sudden loss, drop in blood pressure is more prone to developing anterior ischemic optic neuropathy. The Food and Drug Administration and the World Health Organization have conducted fairly extensive literature reviews and have not found conclusive evidence of a causal relationship between the use of these medications and non-arteritic anterior ischemic optic neuropathy. A recent study by Nathu et al. In the Journal of Neuro-Ophthalmology in March of 2015 found no link. This is the largest study to date, but it was not a randomized prospective study. It's just a literature review. I've had a couple patients that have taken these medications one time and had ischemic optic neuropathy in one eye, and it was very scary for them and did not recover vision. But that's just anecdotal. So I think the FDA recommendation that patients who have any significant visual loss while they're taking them, or if they've had anterior ischemic optic neuropathy in the other eye, not take these medications. Certainly they do put it on their commercials on TV. So in summary, systemic medications can play a really important role in eye disease. And it's important for all of us to note which the high-risk medications are and to monitor for complications. And it's important for us to know the common ones too, because they can really affect the comfort and well-being of our patients' ocular health. And it's important for eye care and medical providers to work together to address these problems. So that's all I have. Thank you. Any questions or comments? Yes.
Thanks. Lou, that was a great talk. I'm sorry I'm late. Can you tell me, did you talk already about my topical steroids, the inhaled and intranasal steroids? I flipped through the handouts and saw mention of systemic steroids. Do you have thoughts on inhaled steroids and intranasal steroids with regard to eye health?
Yeah, they definitely, studies have shown that they can be linked with the side effects, just like systemic. With other systemic, they can cause a significant elevation in intraocular pressure and are related to cataract formation. Studies, and I can't give you the actual percentages, show that they're a bit less likely to cause cataract and glaucoma than topical, a little less likely to cause them than the oral, but it is really a significant thing and important for everybody to be aware of. Something that I mentioned, that the risk of having a problem is very, very low if you just use them for 2 to 4 weeks. But if people are using them on more than 4 weeks, they should be checked to make sure that they don't have a significant rise in their intraocular pressure.
For what it's worth, there was a Harvard endocrinologist once gave a talk to a room full of allergists, and he spoke at some length about a threshold whereby below that threshold you wouldn't see issues that had to do with impacting the normal circadian diurnal variation of endogenous steroid production. And it was his contention that explains this goofy dose response curve where you don't seem to pick up much below a threshold. And I've always felt like my intranasal stuff was off the hook, and the low dose inhaled steroids probably off the hook with biologic variability. That gets tricky, but do you have a notion that the intranasal steroids are an issue? I know there is a literature where the concern was raised. Nick and I have talked about this before.
Yeah, I haven't researched, the dosages and the risk, but I think that there is a little bit at least, and there are some patients that are more likely to get it, people that have pre-existing glaucoma and diabetes and so forth. So, I mean, I think if they're on it for a while and they get their pressure checked, one time, you're covering yourself, and I think it's probably good practice. If they're using them long term at any dose, I would probably recommend that they get checked at least once. Yes.
Lou, thanks. I hadn't heard about the cilio-choroidal effusion syndrome. Is that related to age, and also is it treatable? If you stop the medication, do they recover?
Yes, they recover, and it's not related to age. It can happen at any age.
It's hard to remember everything about every drug
Yeah.
and all the possible side effects, and even the common ones sometimes. Does EPIC give physicians any help in not having used it, unfortunately? Does EPIC help you in being aware of reasonably common complications that will occur with medication use?
I don't think so. I don't use Epic all that much. I mean, I'm mainly just using it for my surgical patients, but I'm not aware that it does.
Wonder why not?
Part of the problem, I think, was we get so many alerts and warnings that after a while they become fatigued. I mean, and you just glance right over them, and so that's what my problem was with a lot of the warnings that we would get.
Okay. I had a question on pseudotumor. So what kind of visual field deficits do you typically see in those patients? What different kinds have you seen?
Usually don't see much at all in terms of
Like
visual
a
field change. They might have a little enlargement of their blind spot, but
right.
their visual acuity is good and their visual fields look relatively normal.
Do you also see peripheral constriction of like the visual field in some of them? Like just
Not much. Usually they don't, unless it's chronic. It's just the patients that have chronic elevated intraocular pressure that get more significant visual field defects. But the key thing is looking at their optic nerve and seeing the swelling.
Okay. I had a patient recently who had a little bit of weight gain and fluctuations, and then she was on minocycline and maybe some isotretinoin, and she had papilledema. So I stopped those. But do you think those are just triggers for pseudotumor, or by themselves, they can actually cause it? Like, I mean, I always thought there was an association, but I'm not hoping that she'll. I don't know. I mean, have you seen that patients actually?
I've seen patients get better if they got off their medication. Yeah. But obesity is also a very significant risk factor for it too. So they're probably, it can be multifactorial in some patients, I think.
Sure. Yeah. Thank you.
Okay. Thank you all.